2, 1. Please start, ma'am. We are live.
Namaskar and good evening, everyone. I welcome you all for the second day of Emerging Treatment Approaches for Non-Small Cell Lung Cancer and Head and Neck Cancer webinar. And with immense pleasure, I would like to invite Dr. Ladit Mohan Sharma from Jaipur, who is Senior Consultant Hematologist and Medical Oncologist at prestigious Mahatma Gandhi Hospital, Jaipur, for the welcome and introductory note and to set the ball rolling. Over to you, sir.
Thank you. Thank you so much, Gitika. And on behalf of the whole organizing team, my dear friend Dr. Tarachan, I extend my warm welcome to all the participants. And I'm happy that we are discussing all the recent advances. Yesterday, we witnessed the lung cancer portfolio. And today, we'll be discussing about the most common cancer in India, that is head and neck cancer. And we all know about the challenges faced by the medical oncologists, as most patients do present to us in locally advanced stage. Almost 50% of patients, they do have a relapse within 2 years period. And we know that what happens to relapse, we don't have any effective treatment available for them. And the quality of life becomes miserable with the constant chemotherapy efforts. So I'm sure that today we will throw good discussions and lights on the management of advanced head and neck cancers with special focus on the immunotherapy and recent advances. And I'm thankful to Dr. Tarachan for giving me an opportunity to talk to you. A few words about that. So without wasting much time, we open the day 2 of the academic activities. And may I have the first presentation, please, with the intro slides. Thank you.
Thank you, Lalit sir, for a brief introduction and your blessing start. And now we start the session today. I would like to invite, first we have just a swap with a panel to concurrent chemotherapy from Rishabh to Dr. Vijay Patil sir. So I invite Dr. Vijay Patil sir for a concurrent chemotherapy in head and neck cancer. And we know that he's a well-known figure in head and neck cancer from India and internationally. And he's a Senior Consultant and Research Director Research in Hinduja Hospital, Mumbai. So Dr. Vijay Patil sir will be speaking on concurrent head and neck cancer.
Thank you. I hope the slides are visible.
Yes, sir.
Yeah. So let me start. Now, whenever we talk about concurrent chemotherapy in head and neck cancers, our choices do differ. When we talk about cisplatin fit patients who are ECG performance status 0 to 1, patients who have good cardiac conditions, patients who don't have PTA abnormality, we talk about that we would give them cisplatin. Now, whether cisplatin is to be given 100 milligram per meter square or 40 milligram per meter square, both of these schedules of 140 seems to be acceptable. What is not acceptable is cisplatin to be given in 30 milligram per meter square. So when you look at cisplatin fit patients, cisplatin remains the treatment of choice. Now, can we give something else apart from cisplatin? And let's see in the definitive setting. In the definitive setting, the substitute to cisplatin is carboplatin and 5-FU, which means, and mind you, this is just not carboplatin and 1 day 5-FU, it's an infusional 5-FU regimen given at a 21 days gap. So if a patient is cisplatin fit, according to NCCN, we have 2 regimens which can be given, either cisplatin or carboplatin and 5-FU. All other regimens, whether you talk about cetuximab, alone carboplatin, have not shown to have benefit over cisplatin alone. Now, in adjuvant setting, the only regimen which has shown benefit is cisplatin in adjuvant setting. Both 100 milligram per meter square also has shown benefit, and there's data to show benefit with 40 milligram per meter square also. Now, however, when you come to the era of cisplatin unfit, there is very limited data in definitive setting or even in adjuvant setting. We commonly substitute cisplatin unfit patient with cetuximab, but that data comes from bonus study, and in that study, we always selected patients who were cisplatin fit. And it is not considerably used because of the high cost. This might change now with the availability of generics. Carboplatin 5-FU, I have a series of 12 patients in which it was given. It's not an easy regimen to tolerate with a high incidence of DYPD in India, giving 5FU infusional along with RT is going to be difficult. We commonly replace in cisplatin unfit patients carboplatin. Now, this is the commonly we do it, but there is no evidence that there is an improvement in benefit with this. 5FU hydroxyurea is another regimen is not so commonly used in India because of lack of experience. This regimen is commonly used in Chicago. Paclitaxel carboplatin is another regimen which has been used in definitive setting, but it's again not that commonly used in India. Now, I'll focus on one of the newer regimen which we developed and got published in JCO this January itself. The study was done in patients who are cisplatin unsuitable. I'll come to the criteria for cisplatin unsuitability in the next, but this was a pragmatic study in which patients were randomized to radiation or docetaxel plus radiation with 2-year disease-free survival being the endpoint. Now, what were the reasons for being cisplatin unfit will come in the slide after this. Pretty large study of 356 patients, and nearly all patients were used for the intent to treat analysis. Now, when you see the study, this was cisplatin unfit patients. Very rarely you would see patients above 70 years of age being taken in the trial, which here constitute to around 15 to 17%. If you look at the median age, it's 63, 61. The median age in the weekly versus 3-weekly paper of ours was around 44. The same median in nemotuzumab paper was also around 45. In the DCDCF paper was around 45. So you can see that dramatic shift in the age which is there when you talk about cisplatin unfit patients. The second thing we must understand that out of 10 patients you see in OPD, if you carefully see the criteria, 4 will be cisplatin unfit. Many of them have a PS2 status. Now, if you look at the hemoglobin also in these patients, hardly half of them will be having HB below 12. Now, this is the interesting chart. Why patients are cisplatin unfit? This can be because of low creatinines, can be because of sensorineural loss. According to McKenzie analysis, addition of chemotherapy to RT in PS2 patient does not benefit. And cisplatin, that is one of the relative criteria, cisplatin immunity. Patient had uncontrolled comorbidities like type 2 diabetes, hypertension, or patient having severe weight loss. Now, in India, most of the patients are not treated by IMRT, especially in a government setup. They would be treated with 2-dimensional therapies. What it shows is, even in this patient, if you carefully plan therapy, with docetaxel and RT, the compliance to RTs is good. And education interpretations interruptions are few. Docetaxel also is well tolerated. Now, even the side effects, if you see, yes, mucositis was more common with docetaxel. Dermatitis is also more common, but that doesn't lead to more interruptions in the radiation, which is important. So, side effects do happen, but understand these are cisplatin unfit patients. If you see only RTM also, you would see that 90% of patients getting mucositis, 90% getting odinophobia. So these are unfit patients. Remember, you would get side effects in them. Late adverse events also do happen, but mainly it is electrolyte imbalance to happen. So does adding docetaxel to RT over RT alone in cisplatin unfit patient benefits? Yes, it surely benefits. The disease-free survival jumps by around a proportion of 12%. Same, and it's seen all across. You could see all across. Elderly, PS2, in fact, the benefit is more in PS2. If the HB is low, still the benefit is there. So the benefit is all across. It benefits in all subgroups. Does it improve the overall survival? Yes, there is a benefit in overall survival to the tune of nearly 9%. And again, in overall survival, also the benefit is seen across all subgroups. The interesting thing is this patient had more side effects. Does it impact the quality of life of these patients? To see if the change in quality of life, if you see with respect to the baseline at 6 months, and I've selected 6 months from the start because 3 months will be the treatment, and after the 3 months will be a gap. And the first response assessment actually happens at 6 months from the start of the therapy. And you could see that the decrement in quality of life, a decrement of 6 units in the fact is considered a decrement. So at 6 months, a decrement in trial outcome index. If you look at this, in docetaxel arm, it was radiation arm, it was seen in 35% as opposed to 25% in docetaxel. Why is this decrement more in the radiation arm? Obviously, side effects did happen more in docetaxel. The reason being, in this patient, the quality of life was continuously collected, and hence you have captured the quality of life even when the disease came back. And this is important. Normally, when we see quality of life in studies, it stops with progression. So you would see if one arm is going well above and one arm is going behind, the quality of life is a match of this arm going above and this going below. We never see this deteriorated quality of life in patients who are progressed. Now here, this has got captured. You see, and this decrement, you will see higher in FACT-G score, FACT head and neck score, trial outcome index score. So we need to be aware there is lower decrement with docetaxel, which is in coherence with that this is more. Now this is important, and if you read at Dr. Ian Tannock's lecture, he will always tell you it's better to seek quality of life with respect to decrement, increment, and as individual or proportions, then looking at the median or average values. We are used to seeing the curves. These are the same study, same curves. You could see at 6 months, it actually doesn't show any difference. The reason is this all negates out with median. And that's why it's important that when you're looking at quality of life, you don't only look at the line diagram, but you also actually request the authors to give that data in proportional forms as how many it was improved, how many it was decreased, how many it stabilized. Because this data sometimes becomes more important, because this is what you would be telling the patients. You are not worried that in population the quality of life, what happened. You are worried in what would happen in that patients. So with this, we concluded that addition of docetaxel to radiation actually improved survival, and also in patients which are cisplatin eligible. This paper has now got published in JCO and is there in public domain. I thought this paper has not got that much attention. You always talk about cisplatin, and hence I decided, with the permission of Tarachand, that I would present this paper in detail. And I'll stop here, and if there are any questions, I will take them.
Thank you, sir, for wonderful presentation, sir, and explanation, sir. What is the preferred in cisplatin individual, carboplatin or docetaxel?
So if you see, if the patient is cisplatin unfit, carboplatin Tara, there is no data. There are actually 3 negative trials of carboplatin, even in cisplatin fit patients. Cisplatin fit patient, RT ek arm mein, one arm is RT plus carboplatin, and they have been compared. And in fact, the summary of this is that in McKenzie analysis clearly says that single agent carboplatin is as good as giving RT alone. So if you have to treat the patient, you treat with docetaxel.
So, sir, we should expect the new trial with the docetaxel versus cisplatin in cisplatin fit patients.
So docetaxel with the cisplatin has, I think the latest I know is completed 320 patients, and we are far. We need 600 patients. So in next 2-3 years, we should get those results of docetaxel RT versus cisplatin RT, but it may take time more than that. The trial was not planned to show immediate benefit. The trial was planned on the basis that cisplatin in long term gives rise to a lot of metabolic syndromes, hyperlipidemia, cardiac events, such kind of syndromes. Docetaxel has not shown to have that property. So the idea is, even if the curves are similar at the start, after a time, the curves should separate. If the hypothesis of this trial is correct, that docetaxel won't lead to late adverse events, which like metabolic syndromes and obesity and cardiac events would decrease with docetaxel. So the idea in that trial is you would have to wait for 5 years and 6 years of follow-up. Then only that separation would be seen. It won't be seen before that.
Okay, sir. Any questions from audience?
Yeah, Dr. Vijay, one small question. I am Lalit here. Like you mentioned rightly about carboplatin, cisplatin. Am I audible?
Yes, you are audible, sir.
Yeah, thank you. So you mentioned about carboplatin. You mentioned something about hydroxyurea that in Chicago they are using.
So I'll tell you, sir. That is a regimen by the Northern Western University of Chicago, 5-FU hydroxyurea. This was, if you remember, sir, regimen was used even in the DECIDE study of induction chemotherapy. This was one of the regimen which was used in the standard arm. Also, this has been used in another JCO publication of Janet et al., in which they use it 2 ways. They use it in both in cisplatin fit patient also and cisplatin unfit patient also. Cisplatin unfit, they tried it post-salvage surgery when patients cannot be given cisplatin. They had given observation versus RT plus 5-FU hydroxyurea. The other regimen they had used it is with in cisplatin fit patient. But what we must understand is when 5-FU hydroxyurea is used, it causes a lot amount of mucositis. And so your radiation oncologist needs to be aware that you are going to use 5-FU hydroxyurea because the Chicago University actually plans the 5-FU hydroxyurea with a split course. So they give radiation and 5-FU. Then there's a planned break. There's a planned break for the mucositis to subside, and then they complete it. So after 4 weeks, there's a planned break. So we must understand that if you're going to use 5-FU hydroxyurea, it cannot be the routine use 5-FU hydroxyurea, or else the patient will have tremendous amount of mucositis. It would be beneficial if your radiation oncologist is going to follow the Chicago schedule or split course RT, and many radiation oncologists actually are opposed to it. And that was one of the reasons why the DECIDE study never recruited completely, because many radiation oncologists consider a split course schedule to be inferior in head and neck cancers.
And one more small query about you said docetaxel. So any inputs on Pacli versus docetaxel? Pacli is much more friendly and we are used and economic also.
Sir, we haven't used paclitaxel. The reason why we used docetaxel in the study was because there was there was phase 1, phase 2, phase 1 data available, and also there was a study in cisplatin fit patients done by RTOG 0234, which compared cisplat cetuximab versus docetaxel. Both arms they had given cetuximab, and it did show that docetaxel was good tolerated as opposed to cisplatin cetuximab, and actually had a survival advantage. And that's the reason why we had selected docetaxel. So docetaxel, we had thought that okay, if in that study of around 250 patients it had a survival advantage, it was a good enough drug for us to use. But the good thing is that the dose of docetaxel 15 milligram per meter square, dose reduction to 12 milligram per meter square hardly gives rise to neutropenias. The problem with this regimen is a mucositis comes a bit early and dermatitis can happen. So you need to be careful with respect to mucositis and dermatitis. That also in Tata, most of the patients were planned with cobalt. So the skin doses are higher. So I am very sure if this planning was done with IMRT, we may have not had so much amount of dermatitis coming into play.
Thank you. Thank you so much, Dr. Patil. Thank you.
Thank you, Vijay sir. And now we are moving towards the next session, that is a panel discussion. Choosing patients and selection of therapy in borderline resectable head and neck squamous cell carcinoma. The session will be moderated by Dr. Rushabh Kothari. He is a co-founder of Oncovin Cancer Center and senior consultant medical oncologist, Narayana Multi-Specialty Hospital, Ahmedabad. The esteemed panelists are Dr. Harsh Dhar. He is a consultant head and neck surgeon, Narayana Super Specialty Hospital, Kolkata. Dr. Rohit Rovelo is assistant professor medical oncology at Ananta Institute of Medical Sciences, Jaipur. And Dr. Devesh Goyal is a senior consultant medical oncologist, Fortis Hospital, Jaipur. Dr. Tej Pratap, consultant cancer surgeon at Narayana Super Specialty Multi-Specialty Hospital, Jaipur. Dr. Abhishek Parikh is a senior consultant surgical oncology at Renova Group at RHL Hospital, Jaipur. Dr. Tej Prakash Soni is a senior consultant radiation oncologist, Bhagwan Mahavir Cancer Hospital and Research Center, Jaipur. And yes, so over to you, Rushabh.
Good evening. Thank you, Dr. Tarajan, for this opportunity. I hope all the panelists are available.
No, only sir, Dr. Manish Gautam is not available.
Yeah, in
Okay.
medical, from medical oncology, there are Dr. Devesh Goyal and Dr. Rohit Rovelo.
Sure.
From surgical oncology, Dr. Tej Pratap, Dr. Harsh Dhar, and Dr. Abhishek Parikh. And radiation oncology, Dr. T.P. Sir.
Okay. So, next slide, please. So this is an interesting topic. As we all know that head and neck squamous cell carcinoma, especially over cavity cancers, are very common in our routine practice. And unfortunately, most of our patients are in advanced stage. Stage 3 and stage 4 is much more common than stage 1 and stage 2 in our practice. outcomes of oral cavity disease without surgery is dismal, and most of the time surgery followed by adjuvant RT plus minus chemo based on histopathies are standard of care. Next slide, please. So now I will be talking on borderline resectable disease. So I would like to ask my medical oncologist first, Dr. Rohit Rebello, what is borderline resectable tumor as per you in your routine practice? How do you define that?
So I think borderline resectable tumor, in clinical trials has been defined as this disease that basically buccal mucosa primary with the peritumoral edema going above the zygomatic arch, tongue primary with extending below the hyoid bone, extension of the into the vallecula, and extensive skin involvement. So basically, these are the factors in clinical trials that they've defined where probably a complete resection would not be possible. So this is what what our surgeons would define as borderline resectable and refer to us for neoadjuvant.
Okay, so in your practice, generally it is surgeon who will define borderline resectable and send the patient to you.
Yeah, in my practice, it is the surgeon who decides on these oral cavity, especially, right? So in the tumor board, it is the surgeon who's given the primary role of deciding whether this patient will eventually come back to surgery.
Okay, Dr. Divyesh, if there is any other point of view from your side.
No, definitely. Goal is hand of the so surgeons already define that resectable or borderline resectable. But definitely surgeons choice is first, and definitely in each and every patient I refer to the head and neck surgeon, EP surgeon or onco surgeon for operability. If they suggest that this is the borderline, then definitely, or if there is inoperable. If they initially operable, then that is fine, resectable, and they will define that this is resectable, borderline, or inoperable.
Okay, so Dr. Harshdar, how is the borderline defined at your institute? So is it very clear, like operable versus borderline versus inoperable, or it depends on surgeon who is doing the surgery, he defines, or it is based on some strict criteria?
No, hi. I'd like to first say a very good evening to everyone, especially to Dr. Tarachan Boss for organizing this webinar. Coming to your question, Dr. Rishabh, it is in our department, we are 3 head neck surgeons, but we work jointly and we take the decision jointly. So, and more or less, as you have said, we classify patients into operable, borderline operable, and frankly inoperable. So the definitions are similar to what has already been mentioned by my other esteemed colleagues. I would just like to add one thing, that the extensive skin involvement, that becomes a very subjective factor. But more or less, we declare it as borderline inoperable whenever, the skin ingression is also more or less close to the hyoid, or if it is extending towards the parotid space posteriorly or reaching near the tragus or the pinna. So in those areas, obviously, we call it off as a very extensive skin involvement, because actually speaking, all the other factors have proper definitions, but extensive skin involvement is something which becomes very subjective. So some amount of subjectivity is there for that factor amongst the various surgeons. But having said that, we take 3 of us take a joint decision together for our patient, and of course, in a tumor board along with our medical oncologists.
Dr. Abhishek, if you want to add anything.
Sir, I'm absolutely agree with Dr. Rabelo and Dr. Dhar also, and it is absolutely a tumor board decision, and it depends on the clinical findings as well. As Dr. Dhar rightly said, that definitely the extent of the skin involvement is a major, it's a very subjective thing, and the subcutaneous edema, then definitely it should be accurately examined clinically, because definitely we should classify these tumors very accurately. Otherwise, we will be in trouble deciding the treatment part.
Dr. Tej Pratap, if you have any other opinion.
Yeah, the same thing. The only thing I want to add, like it's a bit in gray area actually. A borderline definition, it could be resectable for some surgeons and it might be inoperable for some surgeons. If we see this definitions comes especially in the area where we see the high ITF involvement. So if we see it's around 2 centimeters from the sigmoid nodes. So if there is a disease which is just going above the sigmoid nodes, we can say it's a candidate for like neoadjuvant treatment, like because we are not certain about the getting the margins there. But again, if this patient is not responding to the chemo and the disease is stable, again this patient could be a candidate for the surgery because we want to give him a chance for curative intent. That's what Dr. Harshar told and Dr. Abhishek told. I completely agree with that.
Tumor. So clearly it is not operable. So you want to treat it differently, but you don't want to call it inoperable upfront. What is the reason behind it?
Sorry, sir, I didn't get you.
So why you don't want to call it unresectable upfront and do a non-surgical treatment rather than pushing it for NSCT and trying for surgical treatment?
That's what I want to convey, sir, because this is again a gray area. Like if the tumor is going into the high ITF, still it's resectable, but like we used to do in Tata, whenever disease is going up to in the high ITF above the sigmoid nodes, we used to give neoadjuvant treatment in those patients to reduce the tumor. But if the disease is responding, then it's well and good. But if it's not responding and the disease is stable, these patients are still have a chance with the curative intent because we can still get a margin by doing the ITF clearance.
Okay. Dr. TP Soni, if these patients are not undergoing surgery and are undergoing definitive CTRT, what is the expected result out of it?
So you want to say if they are not going for
surgery. So these patients were born
some network problem. Hello. Hello. Hello.
Rishabh, you are not audible.
Hello.
Rishabh, you are not audible.
Hello.
I think yes.
हाँ बताइए.
I think Dr. Tej Prakash Soni, Rishabh, are you back?
Yes, yes.
Yeah, please go ahead. Ask your question again to Dr. Soni.
Okay. So, Dr. Soni, if this patient is not undergoing surgery and getting upfront CTRT, then how is the outcome expected?
Outcome compared to surgery. See, if any tumor which is very locally advanced tumor, especially oral cavity cancer, it is if it is T4A, T4B lesion, and if it is unresectable and it is being treated by neoadjuvant chemotherapy followed by radiotherapy or concurrent chemoradiotherapy, so we can expect 50% tumor failure within 50% failure within 2 years, 50%, more than 50 to 60% failure within 2 years. So chances are not good. If suppose it is locally advanced disease, it's going to fail within 2 years. Yes.
Rishabh, may I add a point?
Sure. Yeah, sure.
Yeah, so if we take whatever studies are there, majority of them which have looked at non-surgical treatment, radical RT or CTRT for oral cancers, out of most of them, see, one of the few papers which have actually showed any decent results is one from the Chicago group, wherein they have given upfront radiation to T3, T4 tumors, that too the number of actual frank T4Bs, I don't think they had any in that series. And the success rate or the complete response rate in this series was at the max around 30 to 40%. What we are dealing with here are diseases which are frank T4Bs. So to expect complete response in this group is, really the outcomes are quite poor. Along with that, you have the risk of developing osteoradionecrosis. And many a times, because of skin involvement and skin formation, you will not be able to give radical RT in full doses as well. So, yeah, so chemoradiation for T4Bs has to be very selective. One method that we are using in our institution is we are giving them neoadjuvant chemotherapy as a bioselector, and those with good response, we are then subjecting them to chemoradiation, adding radiation, if there is decent response after 2 to 3 cycles of NACT.
So, Dr. Harsh, thank you. You made a very important point that non-surgical treatment for this advanced disease, especially CTRT, is query curative. So very few patients will actually get cured with CTRT. And so we need to push them, especially if there is a chance of resection, we should push and try for resection. And hence probably most of us do neoadjuvant chemotherapy approach. And as Dr. Harsh said, whether you bioselect for surgery or radiation, a responding disease or a responding patient would do better. So it makes sense to push for neoadjuvant chemotherapy and try to achieve RC section. That is the best chance where a patient can get cured. Next slide, please. So this definition was nicely elaborated by the panelist, and has been TMH group led by Kumar Prabhas. So this is how borderline resectability has been defined in most of the situations. But I'm working with various head and neck surgeons from various institutes.
Rishabh sir, your voice is not audible.
Opting surgeons' comfort on which the resectability would be defined. Next slide, please. So for non-surgical or non-neoadjuvant approaches, if we do surgery upfront, the chances of R plus resections are more. Chemotherapy, the overall survival was 12.7 months in one group versus 8 months in the other group. So clearly stating that we should push for surgery, and if needed, neoadjuvant approach needs to be applied. Next slide, please.
ऋषभ सर आपका ना नेटवर्क बहुत इशू हो रहा है.
So am I audible? Were you able to hear?
Yes sir, right now it's audible.
Hello.
Yes sir, it's audible.
Sure. So I have tried to put some situations, and I would like to take the opinion of surgeons. So Dr.
Rishabh, you are not audible.
Dr. Harsh, if you can take that.
Yeah, Rishabh. See, so I'll take each one as you have mentioned on the slide. Midline crossing tongue is definitely not a indication for inoperability. Like in tongue, like we have said that the inoperability is depending upon the involvement of the root of tongue, the plane with the hyoid, and of course proximity to the vallecula. So midline crossing tongue definitely would require either an extended hemiglossectomy or in most cases an anterior two-third or near total glossectomy. So that is definitely not in my checklist for inoperability. Again, bilateral nodes, if the nodes are operable, obviously we will go ahead. If on imaging, I feel that there is carotid encasement, like you have mentioned, point number 4, nodes encasing carotid, we'll have to take a call as in what is the degree of encasement. More or less, we are trained to take up any nodes which are less than 270 degrees encasement for at least a trial like dissection. Try to get a plane from the carotid and then on table take a decision whether the node can be resected or not. There has been a series of about 75 to 77 patients from TMH, which was actually authored by Sudhir Nair sir, wherein they looked at the role of neoadjuvant chemotherapy for neck node. And they did see that in a significant proportion of patients with the N3B nodes, there is some benefit of neoadjuvant chemotherapy in rendering them operable. However, in our practice, unless and until it is more than 270 degrees encased, we would definitely go in for a trial neck dissection and only then render it or label it as inoperable. Point number 3 is lateral pterygoid plate involvement. If we look at the paper which has come from the Amrita group and the NH Bangalore group, they have subclassified, and of course, we have a subsequent publication related to that by Dr. Abhishek Mahajan sir from the radiology department at TMH, where they are now classifying the ITF involvement into various subcategories. So lateral pterygoid plate involvement actually comes under category 3, and more or less, if the lower half of the lateral pterygoid plate is involved, such that you can get definite superior margin, you will definitely go in and resect. If the lateral pterygoid plate high up near the pterygoid wedge, that is the block of bone from which the lateral and medial pterygoid plates arise, the pterygoid wedge, if the disease is close to the upper edge of the lateral pterygoid plate, or if the disease is into the pterygomaxillary fissure high up, this will definitely be inoperable. And even in the Amrita series, where they have resected of patients for a compartmental excision, T4Bs, they have found that maximum recurrences occur where the initial disease was involving the lateral pterygoid plate high up or the pterygomaxillary fissure high up. So those will have to be carefully seen on MR. CT itself is not enough. We definitely depend a lot on, we normally, if there is ITF involvement, what we do is we ask our radiologist to do a screening MRI. Many times in our institute, it is done free of cost for the patient. So as an academic interest, and then we take a call on that. Skull base involvement, of course, frank skull base involvement, squamous cell carcinoma, we will never consider that patient ever for surgery. If at all there is no skin involvement and the radiologists feel that they can radiate upfront, maybe upfront CTRT, but even then, complete response rates are very, very dismal. Skull base involvement, because of the proximity to the brain parenchyma and the dura, these usually come back with fast progression and are mostly treated with a palliative intent. If, of course, many times we have a hard palate disease, which is maybe adenoid cystic, minor salivary gland tumors of the hard palate, adenoid cystic, which have close proximity to the V2 foramen rotundum. Our TMH teaching is that a negative margin in these cases is enough. You do not need 5 millimeter margins for adenoid cystic. A negative margin of at least 2 millimeters is enough. In those cases, we will go do a proper compartmental excision, drill the pterygoid wedge flush with the skull base, and try to take a negative margin on frozen section. So adenoid cystic is the only histology where even with significant skull base involvement, we will still go ahead and try to get R0 or even R1 plus, but for squamous cell, definitely not.
Thank you, Dr. Hers, for nice explanation on all the points. So as I understood, point 1 and 2 are clearly operable in most of the situation. Point 3, based on imaging, you have to decide whether it is whether you are getting superior margin or not. And most of the times, 4th and 5th point are inoperable upfront, and probably skull base involvement is inoperable always, except in adenoid cysting. That is what I understood. If there is anything to add, Dr. Abhishek and Dr. Tej Pratap.
Sir, I want to add something that the first point is a midline crossing tongue. So as an institutional policy, we usually offer the neoadjuvant chemotherapy to such patients because the tongue tumors are aggressive tumors and the chances of the distal metastasis are also high. So usually we feel more comfortable giving the neoadjuvant chemotherapy, but definitely the margin should be, the extent of the tumor pre-chemo should be assessed very properly. So usually the tongue tumor crossing the midline, usually we send a patient for the neoadjuvant chemotherapy as a routine. And the bilateral nodes, of course, those are not contraindication for surgery. But if there is a large nodes with evidence of fixity to surrounding structures, and definitely then those are the candidates where we prefer to give the neoadjuvant chemotherapy upfront.
I would just want to ask, sir, you said midline crossing tongue, you would offer neoadjuvant chemotherapy. Have you analyzed your series as in to see how many of them have actually benefited from NACT and how many of them come back to you, or you're able to, operate them, or is there any basis or any literature? Because
Sir,
this is only, yeah.
The doctor, actually, we are just analyzing. Definitely, we are doing the studies, although it is not published yet. Yes, but if we see the overall, the results, overall survival, there is no difference as such we saw in our practice in the last few years. But definitely there is because if there is a good response, definitely the operative feasibility and the kind of the reconstruction we need, definitely sometimes it make a difference.
Right. I just like to add one point here, Rishabh. NACT in tongue, I think Prathamesh sir had started a small pilot study where, post NACT, if there was near complete resolution, that I'm not sure if the trial was ever done, but there was a hypothesis that maybe instead of resecting, maybe we could offer chemo radiation as an organ preservation. That is a concept. Some centers may, give that because when there is significant reduction, then you might want to do an organ conservation approach. So it is still very exploratory. I'm sure Vijay sir, if he's around, is going to add data to that, mostly against, but that is a hypothesis that has been explored.
So, Dr. Harsh, from what I believe, even there are some surgeons who are sending us when tumor is crossing midline in tongue, they probably want to convert extended or total glossectomy to hemiglossectomy. So I'm not sure that if that is the appropriate way, or is there any data where you can convert extended hemi or total to hemi by NACT in tongue? I'm not aware of the data if there is some.
I think most centers would be operating these patients. So if like Dr. Abhishek's group can, actually provide us with data to the world that, these cases might benefit from NACT with good overall survival and preserving tongue volume, that can definitely be for a good study actually.
So, okay. Dr. Tej Pratap, if you want to add anything.
I'm completely agree with Dr. Harsh. I will not prefer to give neoadjuvant treatment in case of midline closing tongue because in some patients disease might progress and that patient might be inoperable after giving neoadjuvant treatment, especially in the young patients. And the second thing is response of the chemotherapy is usually patchy response. So from what I learned is your resection should not be your resection should be almost same if it was before the neoadjuvant treatment. So that we might be because of the patchy response, we might go closer to the disease in those cases.
Okay, so we have a question on surgical margins afterwards, so we'll probably take it there. I think if there is nothing to add, we'll move to the next slide. So, quick yes or no, do you do PET CT for patients who are locally advanced? So most borderline resectable would be locally advanced. Oral cavity and oropharynx and all that, where nodal disease is there, NCCN do recommend doing PET CT. So do you do that, or CCT thorax is good enough for you?
So especially if there's a bulky nodes, and especially in the level 4, level 3, or might be in level 5, in those patients, it's better to go ahead with PET CT. Otherwise, CCT is completely okay for the metastatic blocker.
Okay. Next slide, please. So now to the medical oncologist, what is your regimen of choice if a patient has been referred to you for neoadjuvant treatment? Dr. Rohit Rebello.
So I follow the standard TPF protocol with docetaxel 5FU given for 5 days, and the TPF regimen. So I prefer a 3-drug over a 2-drug regimen, because the data for 3-drug and the conversion data, especially when you look at the KIDWAI as well as the TMH data, where they've seen the responses and patients converting to be far superior with the 3-drug as well compared to the 2-drug regimen, the survivals being 19 months versus 8 months in patients who did not go in for surgery. So about 20% of the patients, the CMC, there's KIDWAI, there's about 22% of the patients do achieve pathological complete response with the 3-drug regimen. So my preference is 5 days, 3-drug regimen. And I give 3 cycles, assess, and at the most I'd go up to 4, but not beyond that.
Okay. A very comprehensive answer. Dr. Divesh Goyal, what is your treatment of choice?
Divesh was.
Okay, Dr. Rohit, do you do DYPD mutation for all of your patient or some of your patient?
No, unless and until I don't see any unexpected toxicity, right? As a baseline, we do not do, although the European EMA recommendations say that when you use 5FU, you're supposed to do it, but in clinical practice, I don't.
Sure. Next slide, please. So I would absolutely agree with what Dr. Rohit has told. So there was a phase 3 trial for 3-drug versus 2-drug where response rate was drastically reduced when you use 2-drug. So this is a place where you want a good response rate. Choice of platinum, cisplatin would always be preferred over carboplatin in this situation. Of taxane, docetaxel would be preferred over paclitaxel. 5FU 5 days is standard of care, though there are many people who are giving 3 days of 5FU, especially due to issue of toxicity with TPF 5-day regimen. And DYPD, as per Indian data, the positivity rate is around 24.5%, which is 1 in 4 patients would be needing dose reduction or dose modification. But I agree that not everyone would be able to do this. Even the turnaround time is not as quick that you can wait for the report to come and then start the first cycle. Next slide, please. So, Dr. Rohit, your choice of regimen for patients who are not fit for TPF?
Actually, if they're not fit for TPF, then they would not be fit for a radical surgery. So we're not talking about conversion anymore. There, I think, I prefer, giving the standard paclicarbo regimen in case they are not fit for, the TPF, because here we are chasing response. And an unfit patient for TPF probably is not going to go for conversion, is not going to go for surgery, will probably remain unfit. And in these patients, I think giving them either just RT alone or maybe CT-RT with what's presented, the docetaxel data seems quite attractive. I think those would be where I would go, because a patient not fit for TPF, I somehow don't see them being fit for surgery beyond.
Dr. Manish or Dr. Divesh?
Sir, both are not there.
Both are not there. Dr. Tarachand, if you want to add something,
No,
what do you do for
yeah,
TPF unfit patients?
we usually start with the weekly regimen of the paclitaxel or nab-paclitaxel with the carboplatin if the patient is unfit for TPF. And sometimes we consider the distance also from how far he is coming. If he is coming overnight journey, then we usually use a 3 weekly paclitaxel plus carboplatin. Otherwise, coming around, then we use weekly paclitaxel plus carboplatin.
Okay, so as I understand that, see, TPF unfit patient is not something very unusual. There are many TPF unfit patients who would be absolutely fit for surgery. Giving a 5-day TPF to someone who is 60, 65, 70 is really, really difficult, and they will undergo surgery easily. So it is not that TPF unfit patient would be unfit for surgery. Rather, in a routine practice, a significant chunk of your patient would be TPF unfit if you consider 5 days of TPF, and they would be fit for surgery. And your surgeon will push that you give NSCT because they are borderline resectable. So this is something, at least in my practice, it is not unusual. Again, as Dr. Tarachan told, that logistic is also an issue. You can't give TPF.
Sir would request you to conclude your panel discussion.
Sure. So what I wanted to call is that Taxane and platinum is something which is important in TPF unfit patient. Probably docetaxel and cisplatin would be a better idea if you're not adding 5FU. And now paclicarbo OMCT and low dose nivolumab plus OMCT both have response rate of 60% plus in platinum refractory or in metastatic setting. So probably that is something to be explored for unfit patients for TPF. Next slide, please.
Sometimes, Rishabh, we have used then the patients are doing not so good with the TPF. Then we add OMCT and patient responded well.
Sure. Yeah, that we have seen in many patients. I agree. So margins post NSCT, we already had a word on it. There is some study which shows that you can consider post NSCT margins rather than pre NSCT margin, again from TMH groups. And morbidity is, in a study, it has shown to be lower than what it was prior to NSCT. Next slide, please. So do you give, Dr. Tarachand, CTRT for all patients post neoadjuvant treatment, or you would based it on histopath?
As a routine, as per the evidence till now, we are post NSCT, we are giving CTRT to all the patients.
I do practice same. So I think this was the last question. A small comment from Dr. Harsh regarding margins, if you can allow.
I was really hoping, Rishabh, that you would let me off the hook here on margins. It's a very, very debatable topic. I unfortunately was one of the research fellows with Dr. Anuja, who has done a prospective study on pathological response after NACT. Unfortunately, we have not been able to publish it in an esteemed journal as yet. It was a prospective study where all the patients who were off plan for NACT, we marked the induration with sutures, the mucosal and the skin in the minor OT prior to NACT. And after NACT, the surgery was done based upon the pre-NACT tattooed suture marks as the induration, and then the pathological response was looked at. 45 patients out of 60, 45 patients were actually went on for surgery. The histopath of these 45 patients, there were only 2 patients in whom there was concentric response by more than 0.5 centimeters in all the different X, Y, and Z axis to actually allow you to take lesser margins. Majority of them, it was patchy response, as Tej has already said. There is a gradation for the patchy response as well. But having said that, that we normally see that we should take lesser margins. Having said that, we normally take the initial margins. If you look at Vijay Patil sir's and Prabhas sir's 721 or Amit Joshi sir's initial 300 paper publication, or even if you look at the Zong trial, all of them actually have taken post-NACT margins. And the patients we have taken post NACT margins, resected adjuvant RT, have actually done decently well. So probably the point that we can make is that even when you take post NACT margins, because you're not sure of the initial skin induration, even when you take post NACT margins, many a time because of adjuvant RT takes care of whatever tumor islands are left here and there. Of course, there is no randomized trial for this. Whatever data we have trying to extrapolate from breast is not feasible here because that's a completely different disease biology. Our fellow from our institute had actually presented this as a randomized trial in this year's Credo. There again, a lot of ethical issues have been raised, and they have now asked us to do a non-randomized prospective 2-arm study to try and answer this question. So hopefully within the next 2-3 years, let's see if we can generate some data. Till now, we do try to take the pre-NACT margins, but it's very difficult after NACT if you haven't tattooed it earlier. So it's going to be a gray zone. It's really difficult to answer that question.
Thank you, Dr. Hers, for this elaboration. Last question to Dr. Soni. Is there any increase in morbidity post NACT if you are giving radiation, or it is same when you give as an adjuvant without NACT?
See, after giving NSCT, many patients, because of they already develop neutropenia or their weight loss, or many of time their general condition KPS becomes low. So when we start radiotherapy, so we have to wait at least for 15-20 days after completion of last chemotherapy. Then they develop some stamina. Then we start radiotherapy. So my personal experience is that after neoadjuvant chemotherapy, many patients they developed a significant more mucositis compared to radiotherapy, chemoradiotherapy alone. So this is my experience. And if we compare neoadjuvant chemotherapy followed by surgery, then radiotherapy with concurrent chemotherapy, that definitely toxicity is going to be more. But there's a single chance to cure the patient. There is no doubt.
Dr. Rushabh, if I can just add one last.
Sure, I think this was my last question. You can add your point and then we can move.
Yeah, so basically,
because we are already running late.
There's data from Tata which has been come in an abstract form that shows that adjuvant chemoradiation is needed when an ACT is given. I presented it as it's come in an abstract form in 2020 in the JCO. So I think in patients who receive neoadjuvant, definitely I think they have to go for adjuvant CTRT.
Yeah. Okay. So I would agree to that generally we do give CTRT to all patients who have received NACT. If there is no other points to raise, then we can conclude and hand over it to Dr. Tarachand again.
Thank you, Rishabh, and for briefly discussing all the points of this gray zone area of the head and neck cancer. And thanks to all the panelists for meaningful input. Now I invite for Dr. Lalit Mohan Sharma sir. He's a senior consultant at Mahatma Gandhi Hospital Medical Oncology and in charge of the pediatric unit. He will be talking on optimizing treatment for recurrent metastatic squamous cell carcinoma of head and neck with immune checkpoint inhibitors. Lalit Mohan sir, please, over to you.
40, please stop recording.
and he will moderate the session on a panel discussion management of recurrent metastatic head and neck cancer. His panelists are Dr. Ashwin Kumar Samar. He is a senior consultant, Department of Medical Oncology, Bhagwan Mahavir Cancer Hospital and Research Center, Jaipur. Dr. Anu Raj Purohit, consultant medical oncologist, NIMS Medical College and Hospital, Jaipur. Dr. Ankit Agrawal is a senior medical oncologist, Gitanjali Hospital, Udaipur. Dr. Deepak Shukla, who is a senior consultant medical oncologist, Manipal Hospital, Jaipur. Dr. Chakor Vora, consultant medical oncology and hemat-oncology, Sassoon Hospital, Pune. Dr. Amit Kumar is a senior consultant medical oncology, hemat-oncology and DMT, Medanta, Patna. Now I would like to invite Dr. Arun Chandrasekhan for a panel discussion.
Thank you, Tara, for the invite. I've not been keeping well for the last few days, so these were some slides which I put together a few days back, and unfortunately I don't think we have a surgeon or a radiation oncologist, so there were some questions which have been, which I will modify for our medical oncology colleagues. So actually I got to know today that this is supposed to be a sponsored session, and they had sent the slides 2 days back, but I've already made the slides, so we'll keep with what we've done so far. I'll just share my screen for now. And I think Dr. Anu is not here, but the rest of the panel, I think Dr. Seem. Yes. Hi, Dr. Ankit. Hi. Dr. Deepak.
Yes.
Hi. Okay. And Dr. Chakor, Dr. Amit, and Dr. Anshul. I hope the rest of the panelists are here. Okay. So again, thank you for the opportunity. Let's put this in full screen. So what we're going to discuss is some of the initial parts are some rare presentations, which may not be that common, but if you see them, then what would be your plan of action, or what would you do in practice? So there are no right or wrong answers over here. It's like what would you do in your practice? And in my practice, I see very few head and neck cancers as of now in Kerala. So I think you guys are the more experts over here. So the first case is an oligometastatic disease. So this is a fictional patient, 55 years, present with a carcinoma tongue, T2N1 disease, underwent surgery followed by adjuvant RT, was an observation after that, and after 1 year, that's more than 12 months later, PET scan was done for a follow-ups. The patient was asymptomatic, but somebody got a PET scan done, and it showed 2 lung nodules in the left lung, which is there. So this is a image where you can see 2 lung nodules in the patient. He's got a history of smoking in the past as well. So the first question I would ask Dr. Asim, would you, the PET scan shows no other disease per se. Would you consider curative intent for this patient, or would you consider palliative? And do you think this could be a new primary, or could it be something related to the head and neck cancer? This is after 12 months. So in your practice, if this patient comes, would you treat it as a palliative or a curative case?
No, 2-3 questions you have asked, Arun.
First one.
It is surely it's secondaries from the previous head and neck cancer. Okay. And it is multiple nodules in the lung, and they are situated in the periphery, and they are well rounded. So it indicates like it's the secondaries in the lung. Okay. And both are not biopsiable because they are hidden behind this scapular bone. So approach is difficult to do the biopsy. So this is the thing, and they will not take, I guess, an uptake in the PET CT also, because they are not up to the size of 1 centimeter even.
Okay.
Yeah, so one answer is there's mets from the head and neck cancer, and biopsy, they are not biopsiable looking, and surgical opinion is to remove them. Metastectomy can be offered, so surgeons will tell that they can do or not. But I guess they are situated in periphery, so they can palpate and remove and resect. But suppose the situation is in the central side, so they can't do the surgery. But in this case, surgical opinion will be very beneficial if they can acquainted for this surgery, this kind of surgery in the center.
Okay, so curative option would be
they can attempt it. Yeah.
Dr. Ankit, now I'll just change this image a little bit. This is a 2 centimeter lesion in the periphery, single lesion. It's got spiculations. it's different from what Dr. Asim has described. This is a different case. You have a single lesion and it looks like the radiologists say, this looks like a second primary. There is a doubt. So would you ask the surgeons to take it out? Or would you say like this is head and neck cancer, bad prognosis, we'll still treat as palliative?
No, I think if it's a single lesion, we should definitely go for a curative intent. I think I'll speak to my surgeon and ask him to get it removed, because it still remains oligometastatic disease, and I think we should get it removed. The metastatic should be done.
Okay, so I think that's a good point there. One more thing before moving on, Dr. Dr. Deepak. Dr. Deepak, would you consider SBRT in this case? Two scenarios where one is you have this is operable. Would you use SBRT in that case because it's less harmful to the patient? You don't want him to undergo a big procedure because tomorrow he might have mets again. Or, would you say, no, we need surgery per se, no SBRT?
So
would you refer to these radiation?
Yeah. So again, Dr. Arun, as you previously mentioned in the beginning, that this scenario as such in clinical practice is very rare. So for a head and neck cancer presenting with only two means isolated lesion, but let's say in these patients, as we are discussing that one of the differentials is possibly a second primary in lung, because the risk factors for both lung cancer and head and neck cancer are the same. So that is a major differential. Again, based on the limited experience that I have, it is difficult on the biopsy to differentiate whether the squamous cell carcinoma, if the histology is similar to the head and neck, it is difficult to differentiate between whether it is a lung primary or it is a head and neck primary. In one of such cases where the differential was a CA cervix metastasizing to lung or a second lung primary, we did a HPV testing from the primary, and the lung primary also showed HPV positivity. So in that case, we assume that possibly it is a CA cervix metastasizing in the lung. Okay, so in this patient, if a single lesion is there, again, it depends. We do not have a level 1 evidence for, and possibly we may not have it in the future also. So this is a discussion with the patient. We cannot say that surgery is better as compared to SBRT. We do not have a head and head result. It depends on the patient choice whether what they wish to do, and any of SBRT is one of the options, and possibly more option which can be taken in the clinical practice.
Okay. I think, yeah, Dr. Asim had said something in the midline, something more towards the mediastinum, which is difficult to do a surgery. Probably in that case, we could consider SBRT. Because
at this time, will it matter that what is the stage of local disease, loco-regional? T4A, T4B or N1, and we are considering the option of curative. If it is a T4B or N2 and N3 disease, then it will be good to say go for the surgery or SBRT as a curative option.
So we'll come to that. We'll see which are the kind of patients you actually go ahead with this thing, resection. So we'll be mentioning that later.
Yeah. One thing, Dr. Arun has done the PET CT and he is saying only lung has the 2 nodules.
No, he's saying that the baseline.
So we assume like primary is controlled.
No, he's saying the initial, I think, Tara, the question was 1 year back, he had a very advanced disease. This one was a T2N1, but what he's saying, if it was a T4B N2 upfront, and then 1 year later, so that we'll come to later, because something which is that aggressive normally should recur within within 1 year. That's what we normally see. So there are some certain criteria which have been discussed, and this is one of them. This is an expert consensus on pulmonary metastatectomy, where they've said that, which are the patients of head and neck cancer, which you can consider this, as Dr. Tara said, it's for a patient who has a DFI of 12 months or more, where you can do a complete resection. And the thing is, on the PET scan, you do not have lymph node metastasis. So you just have that single lung lesion. If you have something in the local area doing a lymph node plus the metastatectomy, that does not have a proper outcome per se. And as we discussed, it's very difficult, differentiating between a lung primary versus a recurrence of head and neck cancer. So even the pathologist will not be able to help you that way. And the table here shows the 5-year survival post metastatectomy in head and neck cancer. So it can range from 5-year survival of 20%, or it can go up to even 60% in some studies. So there's a wide range which is there. This is another match pair analysis which looked at the survival post pulmonary metastectomy. Both of these studies showed there was a significant, survival in patients where you did metastectomy versus no. But again, there are a lot of issues with, doing a match pair analysis, what kind of patients they took, what kind of stage were the initial presentation. And you also have studies to the contrary. And this is the important point to note, that if you have an oral cancer, an oral cavity compared to a larynx or other sites, the outcomes are quite inferior. So this study showed that if you have 23 patients, this was a study where 23 patients, they did pulmonary metastatectomy with oral cancer, and 96% relapsed within 10 months. And another study, there were no 5-year survivors. So in oral cavity cancer, maybe we might have to think twice about doing a metastatectomy. There's no guideline saying you shouldn't do it, but just be prepared that the patient might fail in the future.
Again, Arun, one question is that when we know that in a metastatic setting, with the best available treatment, the median OS is 13 months.
Okay.
Will it be good to go for the lung surgery is an extensive surgery? Will it be good to go?
I think so, yes, because you have the right patient, somebody who is 50 years old, somebody who's got a larynx and then comes with a lung. You do not know if that's going to be a lung primary. I think that's the single most important factor which is going to come for me. If it's more than 12 months and this disease is there in the lung, so you have to choose that patient. More than 12 months, larynx primary, it could be smoking related squamous. You take that out and you might have outcomes which are there. So you might say that, okay, since it's lung primary, it might respond to chemotherapy as well. That's a point, but you're missing the chance of a cure here. So if you're in the private sector and this patient comes to me, I am probably, these patients fit the criteria, I'm probably going to consider it. If it is, if a patient has a lot of issues, has COPD, you cannot do the lung surgery, then obviously I would still consider something like SBRT, and even not that, then I would wait. Oral cancer, I would think twice. So
I think it's depend on the thing is when patient relapses. Suppose patient relapses after 4 years in 2 lung nodules, then we might think of removing the nodule because the disease space is very low. If disease space is very fast, then there is no point in removing the lung nodules.
Absolutely, yeah. Something less than 12 months, I think you're not warranted in that.
Yes.
As such, if the interval is more, there are high chances of this could be a second primary.
True. That I think that's what we're targeting. I think all these studies, most of them could have been a second primary. So that's something to think about. Okay, so SBRT also, there's data for SBRT in lung cancer. You have some trials, some where they compared it with immunotherapy, and the 1-year survival was almost 86% with the usage of SBRT. But again, you have to choose your patients quite carefully. So the next, suppose the same patient who's, we discussed before, the oral tongue, E2N1, he completed surgery and adjuvant RT. And after that, within 12 months, 9 months, he develops a local nodal recurrence. And the PET is not showing disease elsewhere. So this is to Dr. Chakpur. I think I have not asked. So Dr. Chakpur, would you consider this patient for surgery, no disease elsewhere? And prior to surgery, obviously, would you just go ahead with surgery, do an FNEC, confirm, and then proceed with surgery, right? Just your opinion on that.
So if it is resectable, I'll straight away, I'll refer the patient to the surgeon and ask for resection of the disease, because it's 15 months. So doing a biopsy or FNA of that lesion makes probably no sense to me. It is bound to be the same disease. So what else will be achieved by doing a biopsy or FNA? So if it is resectable, do this. Just go ahead with surgery.
Dr. Amit, biopsy or FNAC, or just go ahead with surgery?
I may go with the FNA to prove and then go for a surgery.
Yeah.
There is a possibility of anything that has to be ruled out before because the surgery may be extensive. We may prevent, if the nodal recurrences might be prone for a neck dissection or anything. So before that, it's better to prove before.
So here I'll take the side of Dr. Amit also. We've had local recurrences in that same area, and it turned out to be tuberculosis. The FNAC show was negative. We did a biopsy, and the biopsy came out. There were two nodes which were there, so it came out to be TB. So I think, safety wise you can, but you're right. Means in the same area, same clinical hard fixed node, you can proceed with surgery, but I think the safety wise, medical legally wise, you can do no need of a biopsy. That's the point. I think all of us can agree on. A probable FNAC should show us squamous CA. So after this, Dr. Chakko was right. We did this surgery for this patient, and then after that, post-op, this showed the recurrent disease with extranodal extension. Now, this was supposed to be to the radiation oncologist, but I'll ask Dr. Anshul. It's your choice. Would you tell the radiation oncologist, please give RT, or you'll let him take the choice? Would you, if the radiation oncologist says, yes, I'm going to give RT, would you support it? If he says, I'm not going to give RT, would you say, okay, I'm fine with that? This is within 1 year, 9 months. Dr. Anshul?
Anshul nahi hai around this one. Amit is there and Ankita is there. And Deepak Shukla was.
Okay, I know. Then I'll go back to Dr. Asim. Irradiation within 1 year. This is supposed to be to the radiation oncologist, so I'm sorry, Dr. Asim.
No issues.
But
the thing is, ENE positive, we might tempted upon radiation, but I don't think patient will be subjected for the radiation, because within 10 months, the primary radiation side effect will not be, you can mitigate it. So the only thing is, he might be subjected for the adjuvant systemic treatment, and radiation might not be given to this patient. For some other modality, maybe some more precise or some, but I don't think in RDMG also we are not going to give this radiation to this patient.
9 months. So I think the majority of radiation oncologists will defer doing radiation within 1 year.
And again, I don't know, radiation will be like 30 or 35 radiation, 31 radiation.
True.
If they want to give it. So both, it's not possible only.
One question is from Sajana Chaudhary, that any role of systemic chemo?
Yeah, we're coming to that. We are coming to that question later, adjuvant treatment. So we'll be coming to that in the next question per se. Dr. Ankit, would you consider this patient for proton therapy? Will you refer to Apollo Chennai, which is active right now? I think Tata is just getting ready, but would you tell this patient, please take a second opinion from Apollo? He has, 1 crore per month is his income.
Okay, so
Dr. Ankit.
I don't know. Probably as Dr. Asim Boss said, the patient will not be he will have some sort of side effects after the RT, and going for proton, I am not very confident about going for any kind of radiation to the site.
Okay, so yeah, agreed. It's but there's no harm in a second opinion, and I think sometimes he might be also taken with. We have data for that, so I'll just tell. Yeah, so this would be to Dr. Deepak. If there is no radiation, this patient is complete surgery is done, there's no residual disease, there's no radiation, would you consider any adjuvant chemo? If this is not after RT, there's no RT, so would you consider adjuvant anything, or would you keep the patient under follow-up?
No, I usually in my clinical practice, there is no data to support any adjuvant chemo. But however, there is a lot of force from the surgeon side that
so what is your poison of choice?
Yeah. So means I do not give anything. I observe, and possibly regarding RT, actually we need to know in the first time whether the neck was irradiated. So I think
this was irradiated. This patient is local post irradiation field only.
I think there was a trial from TMH also that was negative trial for metronomic chemo in adjuvant setting instead of adjuvant.
So that's what I want to ask Dr. Chakor also. In your practice, do you give any adjuvant?
No.
In TMH we used to give, but then the trial came out which was saying it was negative. But as you said, pressure from the surgeons? Do you succumb to pressure or do you fight back?
Once I did, but never, not again.
Not
Once
again. Okay, so we stand strong together. Okay. So there is data that salvage surgery is beneficial in patients. You have 5-year survivals. Obviously, oral cavity does slightly better than the other sites of disease. So you have overall survivals which range from 39% all the way to 83%. And giving re-radiation, within 2 years, it's normal, the cutoff. It's within 2 years is very risky. You have to be very careful. There are a lot of factors which you have to consider. And if the patient is sticking all these factors, you might consider the patient within 2 years. But again, most patients, we should not. What about proton therapy? There is data that proton therapy reduces toxicity if done. After 2 months, even this, most of the data is, after 2 years. But if you look at the studies, this one is from the NSCLC and multiple other centers in USA. They have taken patients as less as 14 months and as long as 92 months. So 1 year and 2 months, 1 year and 2 months. They've included patients, or the average number of patients they've taken is around 34 months, which is around 3 years. But they have included patients as less as 14 months. Now, we don't know whether it's the same site or different sites, so those details have not been shared. This is also from America, where they've done proton therapy and taken patients as less as 11 months. Within 1 year, they've included patients with who received radiation and the interval of less than 1 year. So there is some data regarding proton therapy, but again, it's a very subjective thing. I think the radiation oncologist should take the final call on that. Regarding adjuvant, as Dr. Tara said, yes, we have the RMAC study, which said that there is no benefit of giving adjuvant OMCT. So they've looked at OMCT. But the problems with this trial is we know that the dose of methotrexate used was slightly higher than the optimal biological dose. So in metronomic, the lower dose is more beneficial than the higher dose. I think it was 12 milligram per meter square here. Normally we use 9 milligram per meter square. Also, it was double metronomic, not triple metronomic. And now we know that immunotherapy plus triple metronomic is better. So probably using these 3 drugs could have a better outcome. The jury is still out. Maybe a new trial giving adjuvant might, add some benefit. So let's move on to the last scenario. I think we have 5 or 10 minutes more. So this is the same patient. Instead of, having just a local recurrence, he had multiple disease in the lungs, bones, and large nodes. So this is to Dr. Amit. When you have this recurrence, and this is more than 6 months, so it's platinum sensitive, do you do a rebiopsy or just an FNAC is enough for your for your testing? And do you just do which all tests do you do? Do you just do PDL1 or do you do a complete genomic testing? This patient still makes 1 crore per month. Cost is no concern.
So if it's only 6 months, I'll directly go. PDL1, surely it's just since it's a heavy burden disease, I anyhow have to start on chemo plus immuno to this third patient. But PDL1 has got just as a role to counsel the patient. I will say this has the role. So I'll do the PDL1 testing. And comprehensive genomic panel is still in head and neck cancer. I'm not doing.
Okay. Dr. Asim, do you do NGS in head and neck cancer?
No, we are not doing. But Arun, I would like to ask you, in your scenario or setting, have you come across with the 1 CR salary patient?
Oh, yes.
Okay. In India, Indian or NRI?
In head and neck, I'm sorry, no. Head and neck is very far and few. But there are patients who I think are myeloma patients. They are quite he actually told
They must be NRI actually.
Absolutely, you're absolutely right. The NRI, he owns a underwear garment business with 17 factories in the Gulf. So, he was started on a Dara, Tafil Dara, that regimen, the Griffin trial regimen. Cost absolutely no concern, sir. So we do, not everyone, but, the thing is, we're talking, those are the patients who can, actually follow guidelines, but in the practical sense, yes. So we'll come to the practical part also. Anyone else?
So
Does
we'll do
anyone
the
else do
biopsy and
This,
we'll do
this,
PDL1 testing. Yeah.
Okay.
this guy is platinum sensitive, right?
Platinum sensitive. This is after 6 months. This is 9 months recurrence.
Just my understanding is we for the PDL1 testing, if we have a biopsy specimen that is available from the previous specimen,
Yes.
we need not repeat it. For doing a means PDL1 won't change. We
Okay.
could do it on the previous biopsy that was available possibly 8 to 10 months back.
Okay. So that's a point which is there. As I said, for my listing scenario, is there a role of NGS per se? If you look, as you said, not only for PDL1, there is the future. This is not right now, but in the
Yeah.
future, you probably are going to have some form of targeted therapies, which will be coming down the line. There are some farnesyl inhibitors and all which are there. So I think NGS is percolating everywhere. As of now, doing an NGS is not there in any of the recommendations. I think the recommendations mostly are for biliary tract tumors and lung, which is there. But these are some of the potential targetable mutations which are there in the future. So there are some studies with PIK3 and which are happening right now, which may help in the future. And as you said, you can do the testing in the previous sample, and PDL1 does not vary so much. I have not checked the data exactly on that. But if your sample is older, I mean, if it's past 12 months, then in that case, I would definitely, repeat one because of our
Actually,
type of paraffin block preservation is not quite good yet. That's what many of the international
in the
observers
keynote,
what they have said.
okay, so in the keynote trial, they have taken PDL1 from the archival box also. Means
Okay.
basically we want to means extrapolate the Pembro data. So they have done
Okay.
exact percentage. I am not aware, but they have used archival tissues.
Archival tissues, okay. And yeah, moving on. Next, yeah, to Dr. Ankit only. You have 3 scenarios. So the first patient comes with CPS, first CPS score more than 20, which is your preferred regimen, platinum
Okay,
sensitive,
so platinum sensitive, if the patient has if there is the burden of disease is huge,
heavy, yeah.
metastatic, symptomatic patient, huge disease burden, then even if the CPS is more than 20, I would prefer adding chemotherapy to pembrolizumab.
Okay, and
And
which chemo is your preference in practice?
I would like to add pembrolizumab with 5FU platinum.
Okay, and means the 4-day infusional 5FU.
No, most of my patients, they don't tolerate full dose of 4-day continuous infusion. I usually restrict it to 3 days. Honestly,
3
I
days.
don't give it for continuous 4 days. It's very difficult for the patients to tolerate.
Okay, so 3 days, 750 milligram.
750 milligram per meter square, 3 days. I usually give it for 6 to 10 hours, not a continuous infusion, not a
Okay,
24-hour
okay.
infusion. No.
Okay. Dr. Deepak, your preference in CPS more than 20?
So means for any CPS greater than 1, cost not an issue. Pembrolizumab with chemotherapy. I personally do not use P plus F, the classical. I have used as mostly with a good performance status with docetaxel carboplatin, or even mostly because the performance status and nutritional intake is usually poor. So mostly with weekly paclitaxel with the 3-weekly pembrolizumab.
Okay, and docetaxel, are you worried about the DEXA part or no issues with there? Like, they give the prior
No,
DEXA
again,
2 days
very
post?
few. Majority of the patients, it is weekly paclicarbo or but for a very few patients, means docetaxel, possibly we are looking into response rate and some borderline benefit with use of that. So in that patient, it can be selected. Just one more thing, in head and neck cancer, do we have such a clear-cut defined platinum insensitive or platinum sensitive? Means 6 months or greater than 6 months. I think we see, suppose a patient who receives CTRT, he had a complete response with the treatment and he relapses, let's say, at 5 months. So versus a patient who receives CTRT and did not go into a remission. I think the both two biologies will be different. Means is it based on the literature? Should we know that this data comes from basically from the nivolumab data. They have used it in less
Second
than
line.
6 months. But I think in the second line. So, but again, I think based on the previous response to the previous treatment, I think this should be moldable. Means I see it in my clinical practice.
Okay. But then, if you consider that for ovary also, we have patients who, have good response, and then we do a cytoreduction, and then patient relapses in 3 months. Would you consider that as platinum refractory? As per definition, yes.
Ovary is
ovary
biology.
So,
ovary is a different
yeah, I know.
disease per se.
So it'll be difficult to change the definitions per se. But I think, for clinical practice, there's no right or wrong answer. If you feel the patient has done extremely well with, some therapy, giving it again, it makes absolutely no problem. Like even in prostate cancer, you have patients who respond wonderfully to docetaxel, and after 1 year, they progress. There are cases where you can re-challenge with docetaxel. So you're right. There's no, and since head and neck cancer is such a bad disease, keeping all your options open, I think, is the right way. So we have some of the consultants who also, replace docetaxel with doxyacquolib, which does not require DEXA, because they believe that, dexamethasone might reduce the effectivity of pembrolizumab. But we also have data that DEXA up to, 8 to less than 10 milligram does not really harm, the efficacy of pembrolizumab. So we can use just docetaxel, or as you said, paclitaxel. So I'll take Dr. Chakor's opinion also. This time we'll move to CPS more than one. CPS more than one. Again, what is a large burden of disease? Do you prefer pembro, or you feel that the data is not so good with the CPS more than, this is actually CPS between 1 to 20. And that's what I mean by 1 to more than 1. Dr. Chakor? Okay, I think Dr. Chakor is missing. Dr. Amit, can you take that question?
So CPS more than one, chemo plus immuno, both we say.
Chemo plus immuno. And your favorite chemo backbone?
Though the only, only, it's paclitaxel carboplatin.
Paclitaxel plus carbo, okay.
Most patients, if I've heard, I go for nab-pacli in this group of patients. To avoid even the steroids in this group of patients.
Okay. Dr. Asim, CPS 0, extreme regimen or pembro plus chemotherapy?
The justification for immunotherapy is tough, so I would go for this extreme regimen with the CPS score 0.
Okay.
And for previous your 2 questions answered from my clinical practice, we are usually giving pacli-carbo because this is very well tolerated regimen, and docetaxel is tough to give because patient already been irritated earlier, so mucositis is persistent problem, and 5FU is also causing the same thing. So in our clinical practice in Indian scenario, usually I don't give this 5FU or docetaxel based regimen. Only the patient are very fit and relapse very later, and their tolerance is good and supposed to be good. So then we will choose a docetaxel. Yeah.
Okay, I think those are excellent points here about the radiation reactions. So I think whatever clinical experience, you'll know what your perfect backbone is. It's difficult to give 5FU cisplatin for all, but maybe you might have that young, excellent fit patient where you want the maximum response. So we have the keynote 48. This has been discussed before, where you have pembrolizumab, where different CPS scores. The majority of the population were CPS positive, and the thing is, as you can see, 85% had CPS 1 or more, and 43% had CPS of 20 or more. So, Dr. Ankit, do you see this in your practice, like a CPS this high in almost 50% of your patients?
They don't undergo PD-L1 testing because of logistic issues, but definitely not whatever my experience is. I see a CPS of more than 1 in around 25% of the cases, 25 to 30, not more than that.
Okay. Yeah, even same here, like these numbers are quite astronomical, I feel. But this trial actually had these kind of values per se.
I don't know whether a selection bias, I don't know.
Could be, as you say, the population, the Western population of oral cancer is different from our population in oral cancer. So all the HPV, everything, I think oropharynx, whichever is, all this contributes. So CPS more than 20 had the maximum benefit. CPS more than 1 also had benefit, and the overall population also had a combination pembro plus chemo had some benefit. We'll rush to the last few things. What about, as we discussed, do you have data for pembro with taxane and platinum, which is more easily tolerated? Yes, you have Keynote B10, which is a phase 4 trial. They gave Pacli plus carbo. So you also have data for replacing 5-FU and cisplatin. So you can go with something with taxane and platinum. Extreme regimen, yes, I agree with Dr. Asim. If it's CPS 0, there is a lot of slides by Merck who have said that, yes, the extreme regimen has better response rates compared to pembro plus chemotherapy in patients who have a low CPS score. And again, if you can replace 5-FU and cisplatin with docetaxel and cisplatin with cetuximab, and it has similar survival with lesser toxicity compared to 5-FU plus cisplatin. You have monotherapy versus polytherapy. Polychemo, I think most everyone has answered. When you're using chemotherapy, everyone uses doublet mostly. Triplet, very rare. Most patients will not tolerate. And if it's platinum ineligible, what is your go-to drugs? Dr. Tara, do we have time, or should I?
Yeah, you can continue, Arun. This is your time. You can play.
Cross 30 minutes.
Not out. You can play not out. Yeah.
So take my medicines after this.
One question is from my side before this question.
Yeah.
Usually with the cetuximab regimen, what we are seeing that after 2 months or we reach 2 months, then patient experience extreme fatigue. Even we are managing with a magistral acetate and dietitian and etc. So, and the patient usually go with the fatigue or cachexia, and lastly says that please stop that treatment. And finally we conclude till that 3 month only, and then we go with the again 2 weekly cetuximab and try to accommodate. For the skin reaction, yes, that is a very great. We have started using doxycycline from the day 1 of the cetuximab, and we are getting good results that patients are not having any skin reaction. But we are not able to solve the fatigue or cachexia. We have done all the tests, vitamin B12, folate, vitamin B12, and vitamin D, etc. But yes, what others are doing to combat this problem.
Okay, my experience a little less with cetuximab. I've not used the extreme regimen. In TMH, we used to use the Pacli cetuximab, but I think I'll ask a panelist, Dr. Deepak. Do you have that much fatigue with cetuximab? Skin reaction? Yes, absolutely.
Yeah, actually, I cannot say it is solely because of cetuximab. So the chemotherapy also we are giving, so it also causes fatigue. So as I discussed, good number of patients receive a weekly Pacli carbo with cetuximab. So means after 9 cycles, we do a response evaluation, possibly around the 12 cycle mark, they are not able to take. And that time I chemotherapy and switch it to 2 weekly cetuximab. So and possibly magnesium and other things I think Dr. Tara would be doing. But I think it is solely not due to cetuximab. Otherwise, it would be there even with the 2 weekly part. Okay, so it is a combination of both chemo as well as cetuximab that is causing. So I tend to stop chemotherapy and switch to cetuximab early when a patient is having this issue.
For the magnesium, we are doing with every cycle, and we have seen hardly any patient who is less than 1.5 magnesium. But the patient's fatigue is unmanageable.
Yeah, actually, it is correct. Again, I do not know whether it is due to means per se cetuximab. As such, the patients are nutritionally compromised in head and neck cancer. But still, after stopping chemotherapy, means people are able to continue 2 weekly cetuximab. Means still the fatigue and those things are there. Again, means it's an unmet need.
So normally, Tara, when we have fatigue in our patients, the panel I send is on serum cortisol, obviously electrolyte, but focus on this thing, phosphorus as well. Hypophosphatemia, we've detected in some few patients with extreme fatigue, and on correction, they've done wonderfully well. most common patients we see is this in CML, especially patients on imatinib. Now, if all these things are negative and you still have this thing fatigue, I would first stop the chemo and see whether it's because of that. And then I would keep cetuximab as the last option. So that would be my practice. I think personally, you know, what you're comfortable with, what works out. To combat fatigue, as you said, there's nothing specific, but NDASE is something I also go to. I go to the 160 milligram BD dosage as well, rather than the 40 TDS. So, but that also turns out to be a little expensive. But otherwise, that's not really too much that can be done.
Yeah,
Okay.
but Arun, we can do it, lowering the dose of cetuximab and spacing in between the 2 cycles. Because in our setting, in our scenario, Indian patient and no, mostly the North Indian patient, they feel fatigue to come to the hospital every 2 weekly or maybe earlier. So they have a great trauma because they need to stand in the queues and everywhere there is waiting period of time, and their fatigue is mental also. So once you give them some spacing, so it's like you need to come every 3 weekly. There, I guess 20-30% fatigue will be corrected.
Oh, that's an excellent point. You know, that's I think psychological counseling is also an important thing for fatigue management. So
and
I'll start practicing that.
many a times I am not very rigid to the schedule also, like 25th you need to come. If suppose there was some family function or something, 1 or 2 days here and there, maybe the postponement of the regimen is good and they are happy also. So their happiness may overcome the fatigue, I guess.
Oh yes, head and neck cancer doesn't give you time. Please attend all the birthdays, marriages, and graduation functions. That's it.
Means anybody has started using olanzapine for weight gain as such in head and neck cancer? Means any of our colleagues, any of you are using
olanzapine? We also started, but undoubtedly they are very much sedated or some. So that time it's very difficult to decipher like it is because of the hyponatremia or some other problem, fatigue or something. So everything is intermixed. So ultimately we need to stop that olanzapine. Sometimes patients are not tolerating. Most of the patients.
Yes, for the
every time
we
they
are
are
giving
sleepy.
them as an antiemetic also. In the cisplatin regimen, then patients usually complain that they are sleepy. With olanzapine.
Yeah, I think it's a good drug for us. 2.5 milligram seems okay, relatively well tolerated. But yeah, if you have neutropenia and if you have this thing, increased drowsiness, then obviously you would not continue it. But I think it's less than 20%, which in our patients, what I noticed is some patients were on pre-GABA as well. So when you combine both of them, that's when the problems of extra drowsiness do happen. So just look at the other sedatives that you're using as well.
Many times patients are morphine also.
Oh yes,
so that added to the this drowsiness and all that.
So we'll finish off with the platinum ineligible. You have platinum ineligible patients. Which is your favorite chemo regimen? This I'll ask Dr. Ankit.
Platinum ineligible, I usually give a single agent, either Pacli or gemcitabine. I don't combine both gem-Pacli.
And cetuximab, would you add it to the regimen if affordable?
I am not a very big fan of cetuximab, honestly. People have come up with bad side effects. So, but single agent is what I prefer generally.
Okay, Dr. Chakor, as Dr. Ankit said, would you replace cetuximab, panitumumab because of side effects? Almost same cost. Oh yeah, Dr. Chakor is having trouble. Dr. Amit, if would you
think so? There's any need for replacement? More or less, it is same. So it's just who approaches you.
So actually, there is negative data where they've compared with cetuximab, and I think panitumumab performed. Not compared with cetuximab, they've given chemo plus pani versus chemo, and chemo plus panitumumab actually performed worse. So yeah, do not replace. Use cetuximab. If not tolerating, stop cetuximab. Go with single agent as before. So this was one of the interesting things which I found out. There is some data for pembro plus cetuximab. Suppose the patient says that I want no chemotherapy because I want, I hate the term chemotherapy. In that case, there is a phase 2 trial which has used pembro plus cetuximab with a decent overall response rate, which is better than actually the doublet chemotherapies, which was having around 35% response rate. So this is around 45% response rate. So is it officially allowed? No, but outside on a basis of your personal choice, you can use this combination. This part, I think this is where most of our patients come as platinum refractory. Platinum refractory, I'll ask Dr. Asim. Patient comes with progression in 3 months. Patient is affordable. Do you start with Nivo or Pembro single agent, or do you go with triple metronomic with low dose immunotherapy?
So
Your thoughts?
we have started quite a few number of patients on triple metronomic with low dose immunotherapy, and most of the patients are working well. And this regimen is good enough and good for tolerance also, spacing also, and very less need to come to hospital. So I would go with the triple metronomic plus immunotherapy.
Dr. Ankit, your preference also the same?
Started on few patients, not a lot. I have only a couple of patients I have started on low dose with triple metronomic, and I'm very comfortable with this regimen. I think probably it should do good. I just recently started 1 month back. I think it should do good.
Okay, I think
only issue is the severe mucositis.
Yeah, for that, erlotinib doses
Nivo plus metronomic.
Yeah, so erlotinib, I think if you want the dosage can be modified to 100, which makes a decent difference. But I think Tara's patients have too many side effects, yeah. Extreme.
Yeah, concern is the side effect. No, how to?
Tara's patients get scared of Tara only.
Tara is very sensitive. Tara is very sensitive.
Tara is handling the most sensitive, the sensitive patients.
No, because I am using low dose Nivo plus metronomic and good number of patients. But the only problem is that the mucositis, which is troubling us.
Okay. And this is the last question. What is the subsequent therapy? You've completed all the extreme regimens, the keynote regimens, immuno plus chemotherapy. Do you have any favorite go-to regimen after triple metronomic? Patient is still having decent PS. So this I'll ask Dr. Deepak. And then since this is your preference, there's no right answer. What is your practice? Patient has taken triple metronomic, immunotherapy, cisplatin, 5FU, Paclitaxel, Dosi.
Means everything has been used. So palliative care.
Do you use capecitabine single agent or?
Sorry.
Dr. Deepak?
Yes, I missed the question actually.
Oh, means as in after patient who's completed every form of therapy, which you normally use, triple metronomic, immunotherapy, cisplatin, Paclitaxel. Is there some other some things like there is some data for mycidaxine, there's some data for capecitabine, there's even data for pemetrexed. Is there something that you personally prefer or use?
No, I think I offer means palliative care.
Supportive care. Yeah, I think that's also very valid. This thing, Dr. Amit, what patient tells you, I refuse palliative care, and he forces your hand. What would you do?
Basically, re-challenge them with the initial chemotherapy the patient has received. Try to switch to cisplatin from carboplatin. That works slightly better than carboplatin I have seen. And also paclitaxel or nab-paclitaxel if it has been received more than 6 months or 8 months back. Then again, it has got a decent response I can get with those drugs.
Yeah, I think many of us switch from that Paclitaxel to
afatinib.
Afatinib, single agent afatinib. But after triple metronomic, some of us might be a bit hesitant to go back to
there was also some data of axitinib is coming. I think I tried in one patient after taking the full consent, but patient did not respond. And also the one patient was on Paclitaxel and mycidaxine, JM and mycidaxine, but patient was not responding.
Okay. So I think has anyone else used mycidaxine?
So in this scenario, patient is insisting and patient PS is well preserved. I might like to start with the irinotecan. So I have quite a few patients on irinotecan.
Okay.
Initially weekly schedule, then you can, if patient have response with the clinical response, so you can do 2 weekly or 3 weekly. It's very flexible schedule. So irinotecan is a good drug, and they keep on responding. Then you can add platinum also afterwards.
Okay.
So patient tolerate it very well, and there are non-cross resistant drugs, so you can use it.
Okay. We have used capistabin, I think, basis on 5FU, but capistabin has had some effect in, I would say, around 15-20% of the patients as well. Mycidaxi has some data which is there, which is an anti-TB drug, but I think I've never tried it. I think the difficulty finding finding its availability with the injections. So that's what we've seen. So I think this is the conclusion slide. So you look at the TPS score and then make your decisions whether you want to add chemo and pembro. Single agent pembro, I think majority of us will not use because head and neck cancer, some form of chemo going along with immunotherapy is always good. And you have future drugs like tipifarnib, which is a farnesyl transferase inhibitor, which is being studied. You have PIK3 inhibitors, which are also there in the future. So I think head and neck things are expanding later on. And I think that's the last slide. Thank you to the wonderful panel for a wonderful discussion. And thank you, Dr. Tarachand, for this opportunity.
Thank you, Arun, for finishing the head and neck cancer in a single talk for a medical oncology purpose. You have started from beginning of the metastatic and finished till the end. I think nothing has left in the head and neck cancer now. So again, thanks for a wonderful discussion. And I also thanks to my panelists who make this a very fruitful and meaningful discussion and contributed meaningfully. So in the last, I would like to thanks to my all the speakers from the beginning, very senior Dr. Lalmohan Sharma sir and Dr. Vijay Patil sir, and again the moderator Dr. Rishabh Kodari, who moderated session on borderline resected, and Dr. Arun, and the other panelists also, Dr. Harshadhar, Dr. Rohit Rovelo, Dr. Devesh Goyal was, Dr. Tej Pratap, Dr. Abhishek Parikh, and Dr. T.P. Soni sir, and the Arun's panel, Dr. Asim Sawar sir, Dr. Ankit Agrawal, Dr. Deepak Shukla, and Dr. Chakur and Dr. Amit Kumar. And I also thanks to our academic partners who may make the things possible to do this academic session continue. Our AstraZeneca, Merck, Cipla Oncology, Fascinis Kavi, and Cipla Oncology, Lupin Oncology, Dr. Reddy's, MedGenome, and Viatris, Roche, Pfizer, Orient, and Zydus. And also, I would like to thank the Horizon team for conducting this this academic session in a very smooth manner. Thanks, Horizon team.
Thank you, sir. Thank you, all the doctors, for joining. Good night, everyone.